Good afternoon, everybody. This is Dr. Dana Hargunani, Chief Medical Officer for the Oregon Health Authority, welcoming you to another OHA COVID-19 webinar series for healthcare providers. I'm joined by my colleagues here today. They'll be all stepping in to present various information, including Dr. Paul Cieslak, Dr. Tom Jeanne, and Dr. Mautner. We were just all noting that it's been just about a year since we started providing this webinar series. We just want to acknowledge all the work that you've all done over the last year and how much we've experienced in this last year. So thank you for joining us today, and again for all of your contributions. So just to start, on the next slide, we'll show what we're going to cover at a high level. We'll give you, again, some COVID-19 epidemiology updates. We'll spend a bit of time on vaccinations and also talk about some information about COVID variants. We'll sneak in some CDC and OHA guidance, including updates on testing, and then close out with a literature review. I will note we have a lot of content here. We will try to get through all of it. We'll keep an eye on your questions, and we will post all the slides after if we don't get through all of it. With that, I'm going to pass it to Dr. Tom Jeanne.
Thank you, and good afternoon, everybody. So we'll start with a quick epi update here. Next slide, please. So these are our data, cumulative case data as of yesterday. We're now well over 150,000 total cases in Oregon, approaching 9,000 hospitalized, and unfortunately 2,305 deaths since the start, which is just about a year ago now. But the good news is the shape of that epi curve that you can see there, a pretty convincing and steady decline since around January in terms of our case rates. Next slide. So looking at our most recent weekly data, about 1,700 new cases recorded last week, which is down 35% from the prior week. Again, that's been a consistent trend for a while now. Our patients newly hospitalized in Oregon, patients with COVID-19 newly hospitalized, fell by 15% to only 139. And we had a slight increase in deaths over the previous week, however, 86. In terms of our testing, 129,000-ish tests for COVID-19, and we've seen a big decline in test positivity as well over recent weeks. So we're down to 2.8%. Our goal, we're pretty happy for below 5% test positivity, and we'll talk a little more about testing later in the presentation. Next slide. So we've showed some of these tables before. These are age-adjusted data for basically rate ratios by race. So compared to using an index of 1 for whites, you can see what the cases and the hospitalizations and the deaths ratios are for other races here. And these have come down slightly, but only slightly since the last time we shared them. And so you can still see significant disparities across almost every non-white race here. Next slide. This is the same thing for ethnicity, and you can see, again, these have declined a little bit, but not much, and still significant disparities for cases, hospitalizations, and deaths for Hispanics or Latinos. Next slide. So this graph looks a little bit like the epi curve I showed earlier. This is the daily census for hospitalized COVID patients in Oregon statewide. Again, since the early winter, a really convincing decline here. We're now below 150 total hospitalized COVID-19 patients. And then you can see a similar decline in ICU bed patients and patients on ventilators. Next slide. Regionally, similar trend. Of course, the biggest decline is in Region 1 with the metro area, and perhaps a little bit of a plateau there for Region 1, but otherwise a pretty clear decline for all regions in terms of hospitalized patients. Next slide. Okay, so this is a familiar graph. I think this is showing the risk levels color-coded for each county. And the risk levels, as a reminder, are based on case rates or case counts and test positivity. Now, when we were putting together this presentation, the contrast between last month and this month is pretty stark. There was a lot of red, there was a lot of orange last time, and now we have a lot of green and a lot more yellow. So that represents the counties in lower or moderate risk. And the really good news here is these are about to change tomorrow. And so on the, March 9th, the governor announced updates that would be effective March 12th through March 25th. And so then we'll have only two counties in extreme risk, 9 will be at high risk, 12 at moderate, and 13 at lower risk. So a lot of movement, mostly in the downward direction for most counties. Next slide. Turning it back over to Dr. Hargunani.
Great, thank you, Tom. So we're just going to go through a variety of information, starting with on the next slide, just an overview of where we're at with eligibility and then vaccine administrations before we get into specific information about our current vaccines. So since we last joined you, we announced what the future eligibility phases and approximate timing look like for each of those. We hope you've already been able to take a look and dive into this in more detail. On here you can see we're currently in phase 1B, and we've outlined some estimated dates for moving into phase 2, which is the general population. Currently, as you are likely well aware, we are vaccinating focused on the newest group 5, which are people over 65. Or 65 and older, excuse me. We're still also continuing access to vaccine for individuals who were in prior groups. So groups 1 through 4 here, as also ongoing folks in phase 1A. We're making a lot of progress for our older Oregonians. We are currently on the right trajectory to have offered vaccine to vaccinate 80% of older Oregonians by the end of this month, if our current administrations keep up. Moving ahead, we're going to begin with group 6, expected March 29th. That will include a handful of different groups. It includes adults 45 through 64 with one or more underlying health conditions that have been identified as increasing risk for COVID-19 per the CDC. We're also going to begin vaccinations for migrant and seasonal farm workers, seafood and agricultural workers, food processing workers, as well as people experiencing houselessness. We will, as well as a couple other groups, as you can see here. Moving into May, we will be looking at vaccinating certain frontline workers as defined by CDC, which I'll show you in just a moment, multi-generational households, and 16 to 44-year-olds with underlying chronic conditions before we move to the phase 2 general population broken up by age. I just showed you on the right-hand side of this slide, this is the list of underlying health conditions that incur increased risk for COVID-19 per the CDC. The only difference compared to the CDC list is that we did not include individuals who are smokers. I will just call that out. And the next slide is just a high-level list of how people would become eligible based on being a frontline worker. So it's both a combination of the work and whether it puts you in close contact for 15 minutes or longer, and that you can't perform those job duties from home, and the type of work you actually do. This is not an exhaustive list. Again, this list is defined by CDC, and we provide the link here if you're looking towards that. So again, this will be no later than May 1st. Next slide. So there's been a lot of work on vaccinations for so many people across the state. For those of you who've been helping on this front, we deeply appreciate everybody's activities. We continue to increase our pace of vaccinations. We now are at over 1.2 million total doses administered, as you can see on the right-hand side. You can look at this Tableau dashboard that we have on our website, which shows what vaccine type has been administered. You can see now we're starting to show up with new Johnson & Johnson doses based on the initial allocation that was distributed across the state with that very top blue line here. We're expecting to see those doses increase substantially by the end of this month. Per indication from the federal government, we'll be seeing more of that vaccine type. You can see also that the total 1.2 million doses represents over 430,000 people who are now fully vaccinated, and just under that who are still in progress for their series, for the two-part series. There's much more interaction you can do with this on our dashboard, so we definitely invite you to take a close look. On the next slide, you can see from our Tableau site a little bit more about what this looks like county by county. There are a variety of different factors that might impact the vaccination rate at any county level per their population. And it's hard to tease some of that out. It could be certainly the vaccination throughput and the access sites that are available in a particular county. It may have to do with vaccine hesitancy in certain parts of the region, and so forth. So if you also go to our website to look at this dashboard, you can hover over each county and see a little bit more detail per county about those, the population, the number of people vaccinated, et cetera. So I invite you to do that as well. On the next slide, we are continuing to track vaccinations by demographic group. This is somewhat limited in terms of how we can look at this data based on our alert system and how we capture that data. One thing that I'll just point out here, we are continue to be quite concerned about our Latino population in terms of access to vaccine. We would expect that percentage to be much higher based on our population in Oregon and really in recognition of the significant COVID-19 impact to that population as well as others. And so this is an area of extreme focus that we're working towards, which we'll speak to a little bit later. And on the next slide, gives you a little bit of sense, as you can see, based on age group. I'll just make a comment and then invite Dr. Cieslak to come in as he steps into the next vaccine section. So this is when we had a total of 770,000 first doses, and it's just looking at the age range and how that's been flowing in terms of number of people vaccinated, percent vaccinated over time. And as you can see here, now that we're getting through these age bands, as you might expect, we are now seeing a large proportion of those over 80, followed by those over 70, and then in their 60s. So I will pause there and invite Dr. Cieslak to comment further as he then goes into his next slides.
Okay, thanks. Yeah, this was just meant for us to be able to follow how well we're doing at vaccinating those groups that were considered to be the highest priority. And you can kind of see how we advanced week by week to the different age groups. These are only first dose vaccinations, so there's still quite a way to go to get everybody 2 doses of vaccine. And I will say that we haven't yet seen much of a dent as far as the proportion of disease that's reflected in these different age cohorts. But I expect that over the ensuing few weeks, we'll start to see, hopefully anyway, decrements in the proportion of cases, hospitalized cases occurring among persons 80 years of age and older. Next slide. Okay, this is just a review of the COVID-19 vaccines. This slide has a lot of information on it. It's more for your reference than anything, where I'm describing, the dose, the subjects in the phase 3 trial, the age groups for which they are authorized, the interval between doses 1 and 2, and of course the new Johnson & Johnson vaccine in the right-hand column is a single-dose vaccine. Then a little bit about the efficacy trial. Pfizer-BioNTech vaccine looked at everybody more than 7 days out from their second dose of vaccine, and they calculated a 95% efficacy. Moderna vaccine looked at 14 days, calculated 94% efficacy, and Johnson & Johnson ended up looking at 2 different time points and ended up with a 66% overall efficacy against symptomatic infection with SARS-CoV-2. They added a second time point during the trial. The efficacy values that they reached were very similar across pretty much every outcome that they looked at the 14 and 28-day point, but they had more cases when they added the additional 14 days, starting to look at 14 days after that first dose. We are trying to tell people that the trials were conducted in different populations, and so that we don't mean that these efficacy data are directly comparable. They were carried out at different times in different countries with different strains circulating, and that the most important thing is that all of them showed excellent efficacy against the more severe forms of disease, either severe or disease causing hospitalization or death. Next slide, please. So I thought we'd review the Johnson & Johnson vaccine, which only recently received FDA authorization for emergency use. Unlike the previous two vaccines, which are mRNA vaccines, this is an adenovirus 26 vectored vaccine. So they took the genetic sequence for the spike protein and spliced it into an adenovirus that will typically infect human cells. This is a non-replicating adenovirus, so it will get into your cells but will be unable to replicate once there, but it will deliver the segment of DNA that codes for the spike protein, and then the rest of the story is as it is with the Moderna and Pfizer vaccine. You will make some spike protein and then generate an immune response to it. The efficacy trial was conducted in the United States, in several countries in Central and South America, notably Brazil, and in South Africa. It included subjects at least 18 years of age, and globally there were more than 43,000 subjects randomized 1-to-1 to getting a placebo or to getting the adenovirus vectored vaccine. Because they operated in several countries, they had a pretty nice racial and ethnic distribution of their subjects. 59% were white, 45% were Hispanic and Latino, 19% Black, 9% American Indian, many of those in Central and South America, and 3% Asian. They did allow patients with comorbidities to be enrolled, and 41% had a comorbidity, but they excluded immunocompromised patients from their trial. Next slide. What were the side effects? Qualitatively, very similar to the side effects seen with the mRNA vaccines, soreness at the injection site, myalgias, fatigue, headache, but in general, they seem to be less frequent in recipients of the Ad26 vaccine than they did in recipients of the mRNA vaccine. I want to note that fever was seen in 9% of vaccinees, but it was only grade 3 in 0.2%. Grade 3 generally being defined as something that is going to interfere with your activities of daily living, like make you skip a day of work or school or something like that. The serious adverse events were actually more common in their placebo recipients than in their vaccine recipients, so no safety signal there. No cases of anaphylaxis were reported in their clinical trial. So they submitted application for emergency use authorization on February 4th, and it was granted on the 27th of February. Next slide. So here are the efficacy data from that trial. They accrued 468 symptomatic cases of PCR confirmed SARS-CoV-2 infection, and it was 66% efficacious, as I mentioned, in preventing moderate to severe disease. The efficacy numbers differed a little bit in the 3 regions in which the vaccine was studied. It was 72% in the United States, but it retained significant efficacy in South Africa, 57%, despite the fact that at the time, 95% of the cases of COVID-19 that we're seeing were caused by the South African strain, the B1.351 strain, that in the laboratory appears to be able to evade immunity, but we still saw significant efficacy here, so that's actually very reassuring. In preventing severe disease, which was basically defined as people with an SaO2 of less than 93% on room air at sea level, tachycardia, and then a host of other more severe manifestations needing hospitalization, mechanical ventilation, renal failure, hepatic findings, etc. 85%. And there were no hospitalizations or deaths in the vaccinated group after day 28. Preventing hospitalization from day 14 onwards, there were 29 hospitalizations in placebo recipients and only 2 in the vaccine recipients. So it appeared to be 93% effective in preventing hospitalization after day 14. Next slide. This slide is more for your reference than anything, having the storage parameters for each of these vaccines. I want to call your attention especially to the upper right-hand corner where you see the long-term storage of the Johnson & Johnson vaccine. It can be stored 3 months at refrigerator temperatures, so does not require freezing, which is very nice. So there's no thawing involved and no reconstitution. So that is one additional handy feature in addition to its being a single dose vaccine. Next. There are some data out there now reassuringly on real world effectiveness, so observational studies. The first one is in Scotland, where they conducted an open, real-time, prospective observational cohort study. The population of Scotland is 5.4 million, and over the time frame of the study, 22% had been vaccinated. They excluded people who had previously been positive for SARS-CoV-2 and looked at everybody in that date range, December 8th through February 15th, who got their first dose of vaccine. In Scotland at the time, they used the BioNTech vaccine. That's the 162b2 that is our Pfizer vaccine. In addition, they have the AstraZeneca adenovirus vectored vaccine, so both were in use at that time. Their endpoint for the study was either hospitalizations or a positive PCR test within 28 days of vaccination, and they analyzed vaccine efficacy, effectiveness overall, and by vaccine and by age cohort. Next. Okay, so there was higher vaccine uptake among females. Among the second least deprived Scottish index of, let's see, what did that stand for again? It was basically highly vulnerable people are detected by that SIMD index, and the second least deprived ended up being the most vaccinated. Remote rural residents, persons with at least 5 comorbidities, ex-smokers, and persons with very raised blood pressure were more likely to be vaccinated than others. Next. And here you see the effectiveness data that they broke down by different week-long time periods following vaccination. And so the effectiveness appeared to peak at 28 to 34 days following vaccination. The numbers get kind of small, but the effectiveness was 84%, and it appeared to wane a little bit after that time point. But again, numbers are small and the confidence limits are large for that. So 84% at its peak. Next slide. Okay, so then breaking down that 84% effectiveness at 28 to 34 days by different age groups, you can see pretty similar estimates, 85%, 79%, and 81% by different age groups. So the fact that it retained 81% effectiveness among those over 80 is reassuring. And then pretty similar effectiveness, 85% and 94% for the 2 different vaccine formulations, respectively. Next. Okay, and then another large observational study was done in Israel, where they were using exclusively the Pfizer-BioNTech mRNA vaccine. And this was done in Israel's largest HMO, which comprised 53% of their population, I think that amounted to about 4.7 million people. So actually a population larger than Oregon's were included in, effectively included in this study. So they looked at everybody over 16 who was newly vaccinated between the 20th of December and the 1st of February. And then they matched the vaccinees 1-to-1 with unvaccinated controls who were matched on age, sex, sector, that is like the Jewish sector, the Arab sector, neighborhood within Israel, history of influenza vaccination, pregnancy, and then a number of coexisting conditions. Next. So they had 1.1 million eligible vaccinees, almost 600,000 were vaccinated, and they were matched to unvaccinated controls. The outcomes that they looked at were any positive PCR test, symptomatic COVID-19, hospital admission for COVID-19, severe COVID-19, and death. And they followed up these patients until they either met one of these outcomes or had an unrelated death, or for the cases, if their control was vaccinated, and for the controls if they were vaccinated, and then of course the end of the study period. Next. So looking at the time frame, starting at least 7 days after dose 2, which was what Pfizer used in their efficacy pivotal trial, they found 92% effectiveness against any documented infection, 94% against symptomatic illness, 87% against hospitalization, and 92% against severe disease. They had no deaths more than 7 days after dose 2, so they couldn't really give us a number on that. Importantly, they looked at what they called a proxy for asymptomatic disease. So these are people who were PCR positive, and remember, they're members of a large HMO, so they have their PCR status, and they're looking through their record, and people with no documented symptoms. So they're considering this a proxy for asymptomatic infection, and it was 90% effective. So virtually all of the people who developed SARS-CoV-2 infection without having any documented symptoms had not received the vaccine. So this, when people are wondering about whether the vaccines prevent transmission, I think this is very reassuring and a strong argument to make that if they don't have it in their nose as discerned by a PCR test, then they're unlikely to transmit. Next. And I just wanted to throw together a few data on this issue of transmission. So with the Pfizer vaccine, it did reduce transmission in animal models before the human trials were undertaken. And then I just mentioned the study in Israel where they showed 90% reduction in infection without documented symptoms. For the Moderna vaccine, you may recall that in their efficacy trial, they did swab everybody before giving dose 2. So asymptomatic people who were about to get the second dose, and the vaccine recipients were 63% less likely than placebo recipients to be carrying the virus at the time. So pretty good evidence there. For Johnson & Johnson vaccine, they looked at serology to see whether people were seroconverting. And after day 29, it appeared to reduce asymptomatic seroconversion by 74%. So we have data now on all 3 vaccines that are authorized for use in the United States. Next slide. A couple of vaccines not yet anyway authorized for use in the United States. AstraZeneca has been shown to reduce carriage by 67% after 1 dose, and the Novavax vaccine, at least in rhesus macaques, completely prevented transmission. Next. Okay. So a few slides about vaccine allocation. So as are these yours, Dana?
Yeah, I can take it, Paul.
Okay, please take it from here.
Thanks, Paul. So switching gears a little bit from all the great information Dr. Cieslak just shared, we're going to talk a little bit about vaccine distribution and what we're anticipating ahead. So right now, all indicators at the federal level suggest that we should see a significant increase in vaccine supply as early as the end of March, but certainly into April and May. You may have heard President Biden's announcement that he expected vaccine availability for all individuals by the end of the May. So we still are only getting a several week look ahead to the actual numbers we'll be getting in our state, and we haven't seen a substantial increase coming our way yet, but we are certainly planning for that potential vaccine surge and how we're going to maximize our throughput and particularly ensure that we're reaching everyone, in particular those who've had the greatest impacts from COVID-19. So this slide just outlines some of the work we're doing and our plans for preparing for that surge of vaccine allocations at the federal level. So first and foremost, we are working towards maximizing vaccine distribution through our federal qualified health centers across the state. Currently, we are getting vaccine allocations to a total of 11 FQHCs as starting next week. Those doses will arrive to 11 FQHCs from the state allocation. There are an additional 2 FQHCs that are getting doses directly from the federal government. We know the federal government allocations are looking to expand to a wider number of FQHCs soon, and that we, the state, are looking at trying to expand the FQHCs that we're directing doses to as well, trying to get to as broad distribution through FQHCs in our state as soon as our allocations allow. We have a lot of work happening with our FQHC partners to prepare for that. And first and foremost, this is due to recognition that the population served by our federally qualified health centers really target the populations that have been most impacted by COVID-19 and health inequities. So this is a critical population we want to be sure is being served with vaccine access. There are also a lot of retail pharmacies now involved in vaccination. The federal pharmacy retail program has been really the main source of vaccine for that at the federal level. Pharmacy sites now include Rite Aid, Health Mart, independent pharmacies, Walgreens, Costco's, Albertsons, Safeway, and Walmart as well. We are also distributing some vaccine now to pharmacy partners directly from the state, including Bi-Mart, in addition to the some that we just shared with you. So we anticipate this to be an ongoing and usual source of COVID-19 vaccine throughout this, and we do expect there's more capacity that we'll be able to move through pharmacies. Our local public health authorities have been a critical partner in vaccine distribution and vaccine administration. Again, they have been particularly focused across the state on ensuring access for those that are particularly hard to reach, again, or who face some of the greatest health inequities, and that partnership is critical to us. As you know, early on in our vaccination efforts, the federal pharmacy partnership was providing vaccines in facilities such as long-term care facilities and some other congregate care settings. We are working as that program slows down at the federal level. We are working with partners to make sure that there's ongoing vaccine access to these sites. We're also working to ensure that any of those congregate care settings that weren't included in that program are getting access to vaccine right now. As you know, we've had a lot of high throughput or max vaccination sites that have been a source of getting vaccines quickly and efficiently to people. This does not serve everyone, but it's certainly been an important source of vaccination. And we anticipate, at least for the several months to come, that these will be critical as we see a surge in doses. Not the sole access point, but certainly still critical until we get to a more regular distributive approach down the road. And I mentioned already, there's a lot of populations who are just either not served in the mass settings or weren't served in the federal pharmacy partnership that still need doses getting to them. This is the more resource heavy approaches to getting doses to, for example, homebound older adults or others with disabilities who cannot leave their home. And there's a lot of efforts locally and supported through the state to get there. We have still a lot more work to do here, and everybody's contributions here are going to be critical. And we're continuing to build on our partnerships with community-based organizations, faith-based leaders, and other trusted partners across the state to support vaccine efforts, be that through information sharing, hosting of events, partnering in vaccination efforts, and that will continue to be critically important to reach all populations in Oregon. Moving ahead, as supply continues to increase, we know that there are other access points that we need to build into our distribution. First and foremost, we know that generally, like influenza and other pediatric vaccines, primary care is one of the most important sources of getting vaccine out to individuals. Other outpatient clinics might be well poised to do this as well. Based on the way the supplies come through and the complexity to delivering these vaccines and the logistics, it's been not possible to really do broad distribution to outpatient clinic sites. But as the supply continues to increase and we start to switch the supply versus demand, we do anticipate starting to distribute vaccine to outpatient clinics. And in just a minute, we'll talk about how you might ready your clinic to start participating in this. I can't tell you when this will occur, but I would expect it's for certain the next 2 months, and we are working our strategies and connections to be prepared to do that. We also know that inpatient access points will be critical in hospitals for those who might come through who meet eligibility or before they go to skilled nursing facilities. Right now, it's been hard to get vaccines to hospitals for this purpose, but we're looking at when we might need to, we might be able to trigger that. And then we're also looking ahead at the potential for partnering with employers for employer-based vaccine events. We're anticipating and working with employers right now, looking at this in the not too distant future with some of our agricultural and food processing workers and their employers, where those partnerships are possible. But as we look ahead to the broader frontline worker categories, we're looking at developing partners with those employers as well. Next slide. I just wanted to hone in to make sure that you are all aware of our vaccine website that has information for COVID-19 vaccine providers. Dr. Mautner is going to jump in here in just a second to talk about what you can do to prepare to support vaccination efforts in your community or at your clinic. But please do take a look at this website. I have the link here. You can see in that nice red, bright red-orange button on the top. We encourage you, if you haven't already, to enroll as a COVID-19 vaccine provider if you're interested to host a vaccine administration at your clinical site. And there's a host of really good information on here for all of you, including talking points, provider communication toolkit, information about vaccine storage and handling equipment, and beyond. So we really encourage you, if you haven't taken a look, to go to our website and peek at this. All right, Dr. Mautner, I'm going to pass it to you.
Thank you, Dr. Hargunani. And as a primary care provider, I know that Dr. Hargunani is looking forward to the days, as am I, when our outpatient provider community is able to participate in the provision of these vaccines to the communities that you know well. So the important thing for you to know is that at this time, we have, as you know, a squeeze on the supply, which means that our demand is outstripping our supply. There will come a moment when we will shift to having the supply outstrip demand. And as you were hearing on the prior slides and from Dr. Hargunani now and before, your role there will be very important in a variety of ways. You as providers can enroll on that website, and there are materials there for you to be able to use as well. Click on that link, go ahead and enroll. You can volunteer to support either mobile vaccine efforts or at a site where they're doing vaccination events in your community. Within your clinic site, you can work to develop an operational plan, because you know that once the vaccine becomes available, that you will have a different way to approach your populations. In observing your own patient populations, your own panels, you can identify your eligible patients and let them know how to access vaccine. And in fact, if you can help do some of that vaccine confidence work, trusted messengers are the coin of the realm here for those populations that have questions and concerns about the vaccine, about its efficacy, about potential side effects, about all the different, about the speed with which the vaccines were developed. We have materials to support your own education if that's something that you would like support from us to do on that same website, and we continue to develop more, particularly for those communities that have very specific concerns and potentially culturally specific need for outreach that addresses the concerns that they have developed for very specific reasons and events. So you can, so when you have that trust with your own patients and your clinical colleagues have those conversations, you are prepared with the talking points and the materials to give them the tools to make a decision that will be good for them and for their families. And in the meantime, of course, encouraging ongoing promotion of COVID protective behaviors for those who are not vaccinated is important. Our hope is that as vaccination continues and as our rates hopefully continue to fall, and as individuals, families, and communities witness the changes in their communities and in the freedoms that people feel as a result of vaccination, that they will feel encouraged at least to come talk with you, their trusted providers, about the vaccine. So please take that opportunity and let us support you however we can. Next slide, please. And I am going to hand off the camera.
Hello. Okay, just a few words on variants. We get a lot of questions about these. Next slide. So, you know, like all RNA viruses, there are constant mutations in the genome, and certain things are thought possibly to exert a selective pressure in favor of the variants. Of course, if people have a compromised immune system and develop an infection that lasts longer or that involves more viral replication, then that's going to be more likely to lead to mutations. So the more people that we have who are infected and the longer those infections last, the more likely you are to develop a mutation. Interspecies transmission. So we know that minks have contracted a variant of the virus, and then it becomes that has facilitated transmission among the mink populations. We have seen that in Oregon. Treatment with monoclonal antibodies and convalescent plasma. Again, you're making antibodies to the original strain, and if there is a mutant strain that has less affinity for these antibodies, then you may be selecting for a mutant strain. Prior immunity, same thing. And then, as I mentioned, increased transmission is going to make mutation more likely. The more times the virus is replicating, the more times that their unfaithful polymerase is going to generate some mistake. Next. So what variants are circulating? Well, the original Wuhan strain, which we got very early, remember our first case in the state of Washington in January of last year, has already been replaced by a new strain called D614G, also called the G variant. So what the codes mean is each amino acid has a letter code. So that's an aspartate to glycine mutation in amino acid residue number 614. At any rate, that is become the dominant strain. It is apparently 20% more transmissible than the original strain. And fortunately, current vaccines are still very effective against this strain. And as I mentioned, the more we can prevent infection in the first place, the more we can reduce the likelihood that we'll see variants. Next. So the emerging variants of concern that you'll hear about, so that's kind of the buzzword. CDC has designated these three variants as variants of concern. The B117 strain first detected in the United Kingdom. There are at least 2,400 cases in the United States, including several that have been documented in Oregon. Almost from the first time we started, well, I mean, we as a country started looking for this strain, it was pretty widespread in the United States. It's thought to be about 50% more transmissible than the original strain, and modeling is predicting that it will become the dominant strain in the United States over the next several weeks anyway. The B1.351 strain in South Africa, 53 cases in the United States. It has spread to at least 51 countries. It is also thought to be more transmissible. And this is the one, as I'll show in a subsequent slide, that shows the most concern for potential to evade immune responses engendered by either natural infection with the previous strain or with vaccine. And then the P1 strain in Brazil and Japan, 10 cases in the United States. We have had one in Oregon. We don't know that it's more transmissible, and it doesn't seem to really evade immunity like the B1.351 strain. Next slide. So how effective are the vaccines against these variants of concern? Well, the only data that we had before the Johnson & Johnson vaccine trial, which, as you may recall, South Africa was one of the major locales for their efficacy trial. The only data we had were laboratory-based data looking at the serum from people who had recovered from infection or serum from people who had been vaccinated. And they showed a largest impact on the B1.351 strain. In other words, the biggest reduction in neutralizing antibody capability for that B1.351 strain, and the least reduction for the B1.17 strain, which is good news because, as I mentioned, it's predicted to be the one that kind of takes over, at least in the United States. Most studies on B1.351 show a bigger reduction in neutralizing capability than on the B1.17. Next. So we have identified, I mean, not the Oregon State Public Health Lab, which is still validating its sequencing test, but other laboratories in Oregon have been doing some sequencing and have identified variants in several counties in Oregon, and the most common of them is the B1.17. As I mentioned, we've had several sightings of this already. And in Oregon, we identified a single case of the P1 variant. And I think that's all I have on the variants. So handing it back to Tom.
Thank you. Okay, next slide, please. So I wanted to cover some of the highlights in guidances that has changed lately. As I think most of you probably heard, on Monday, CDC released some guidance for recommendations once you've been vaccinated. And the highlights are, and this is for the general public and everybody who's been fully vaccinated. Number one, you can gather indoors with other fully vaccinated people without wearing a mask. Amazing. You can also gather indoors with unvaccinated people from one other household without masks. So one unvaccinated household, people who are already living together, unless any of those people or anyone in that household has an increased risk of severe illness from COVID-19. And then if you've been around somebody who has COVID-19, you've been exposed, there's no longer a need to quarantine if you have been fully vaccinated. And the exception to that would be if you live in a correctional facility, a group home, or some other group setting, you should still quarantine for 14 days and get tested even if you don't have symptoms. Next slide. So what about being out in public though? So for now, CDC is saying even if you're fully vaccinated, you still need to wear a mask. You still need to keep your distance, avoid crowds, avoid poorly ventilated spaces. And you should not be gathering with unvaccinated people from more than one other household because that's not recommended because they're not vaccinated, they could spread to each other. And then you should still be following all these guidelines if you are visiting an unvaccinated person who is at increased risk of severe illness or death, as I said in the previous slide. Still avoiding medium or large gatherings, avoiding non-essential travel, and watching for symptoms, and then workplace guidance, of course, should be followed. Now, what I did not put in this slide is the kind of specific update for fully vaccinated healthcare personnel. And so where that stands right now is that if you're a fully vaccinated healthcare worker, even with a higher risk exposure, as long as you're asymptomatic, you don't need to quarantine, you don't need to be restricted for work after that exposure. And the exception to that would be if you have some kind of underlying immunocompromise that might affect the vaccine's level of protection. It's not really well understood what all those conditions would be right now, or how much they would impact the protection. And then in terms of travel, right now the CDC's recommendation is still any out-of-state travel or international travel, you should quarantine for 14 days, even if you have been vaccinated. Now in Oregon, we are saying if you travel within 100 miles of Oregon, just across the border to one of our neighbors, we're not really going to count that as requiring a quarantine for 14 days. Okay, next slide. Okay, shifting gears here to school guidance. There are some big changes coming because as of, on last Friday, Governor Brown issued a directive to both the Oregon Department of Education and to Oregon Health Authority to help public schools and make sure public schools can offer universal access to in-person instruction by the end of March for K through 5 elementary, and by April 19th for students in middle school and high school. So all public schools in Oregon will operate under either fully on-site or a hybrid on-site remote instructional model, as long as they meet the metrics. And this, there is a forthcoming executive order that will formalize this very soon too. So individual students or parents who want to do remote learning or have health needs may continue to do so. And in those communities or counties where transmission rates are really high, comprehensive distance learning for all will be an option for those school districts. Next. So together with ODE, we are revisiting and revising the health and safety guidelines in the large document. It's called Ready Schools, Safe Learners. Based on updated research on COVID-19 transmission in schools and some guidance from partners. And we will be issuing guidance to match the directives set out by the governor by March 19th and possibly quite a bit sooner. And so some of these changes may include changes to cohorting, changes to physical distancing, and changes to some of the language around the metrics. So stay tuned for more on that. Next slide. Okay, so we've got about 8 minutes left here. I'm going to kind of go through the testing update fairly quickly, but I wanted to give you a sense for where we are statewide. This is a slide showing basically the estimated or projected daily testing need based on a lot of factors, but certainly the case rate is part of that. That's the blue line. And then the orange line is our estimated actual daily tests performed. And you can see that since about the beginning of 2021, for a couple of months, over 2 months now, we've been quite a bit above the need. So there is no testing shortage at this time. And as I shared at the beginning, our test positivity rate statewide has been declining and is down below 3% now. So really no evidence of a statewide testing shortage. Of course, we still have disparities that we're working on and access issues for testing. Next slide. So big updates. In February, CDC issued a new operational strategy for K-12 schools, and among many other things that included some testing recommendations. All students and staff who develop symptoms at school or have an exposure should be referred for testing. Now we have, at the bottom there, you can see we have our own K-12 testing plan and program in Oregon, and we have 766 schools that are now registered for that. So it's a good chunk of all of our schools. We are offering it to all public and private K-12 schools in Oregon. Testing is required, and this is on-site school testing with a rapid BinaxNOW test. Testing is required if a school is operating in person in a county above what their metrics say they should be operating in person. or if they are doing outdoor contact sports in a county with a high or extreme risk level where that is not recommended. So testing at school is just one of many layers and interventions that can help reduce the risk and respond to cases rapidly to make sure we're not going to get spread in schools. Next slide. So just to give you a flavor of some of the things that we're doing with federal funding and state funding that we're passing through to communities, we're using some mail-in testing resources to make sure that everybody who's exposed can get tested, including the uninsured. We're working with community-based organizations to continue to plan testing events and understand testing barriers in disproportionately impacted communities. And that includes funding some of these community-based organizations for their work. And we're also supporting targeted testing of these populations through a regional framework with reimbursement for uninsured populations. And we have some mobile testing that I'll talk about in the next slides. Next, please. To date, we've had 190 low barrier testing events in the state with over 23,000 people tested. These are kind of mass testing events that are free testing in various communities. Migrant and seasonal farm workers with H-2A or B visas. We've initiated testing of them. Eventually, we'll offer to all farms upon arrival of seasonal workers. And we have now identified regional testing partners for all 7 regions. There are only 7 regions despite going up to region 9, but you can see there throughout the state there, various hospitals. And then in terms of those mobile vans, we have OHSU has 3 vans, OHA has 4 vans that we're working on retrofitting, and several partners, community partners, are receiving vans too for testing. So really great progress there. Next slide. And then I think this is the final one. So we've distributed 750,000 tests to partners statewide, including those Binax Now rapid point-of-care tests. Those are the tests that have a little card and they do require some training, but they can give a result in 15 minutes. So a little over 400,000 of those to 246 testing partners. That includes critical access hospitals, primary care, long-term care facilities, and we have a reserve for K-12 testing as needed for, with those tests. The ID Now is a rapid test that's a molecular test. We distributed 70,000 of those to testing partners in areas with limited testing capacity. And then Thermo Fisher high volume PCR testing, we have distributed 310,000 tests to large healthcare testing partners around the state. And then there's finally additional testing capacity currently on tap at University of Oregon, OSU, and OHSU. Next slide. And that is it for testing. Back to you, Dana.
Great. Actually, if we could just go back quickly, or sorry, we can leave it here. Sorry, Britt, I'm causing confusion here. So just 2 very quick slides, and then I just actually want to call out a couple questions to my colleagues just to make sure with our few minutes left that we have time to make sure we answer a couple of them. There are 2 quick literature review slides that I don't think we'll spend any time on, more than about 30 seconds. This one is about convalescent plasma as a treatment for patients with COVID-19, and the next is around ivermectin. And ultimately, for both of these treatments, they did not show a significant improvement in resolution of symptoms and are not really showing a benefit for treatment of COVID-19. So just wanted to make sure you saw the latest on the literature regarding treatment. These 2 not really recommended now. I just wanted to, it looks like a couple questions have been answered. I just want to call out, let's see, one here maybe for you, Tom. Is there any guidance, safety specific guidance for higher education like community colleges? One of our participants mentions that a lot of high school students attend community colleges, and what kind of guidance and information are we providing for those areas?
Yeah, I'll put a link in the chat question or the Q&A there. There's the Higher Education Coordinating Commission in Oregon. They have issued guidance for higher education institutions, and it's a little bit more abbreviated than the exhaustive kind of K-12 guidance, but it's got some good stuff for higher ed. So I'll put the link in the Q&A.
Fantastic. And anybody want to comment on CDC's recommendation for double masking before we close out?
I'll put a link in the chat about that. There's a, if masking is indicated, then the better the mask, of course, the better we'll do at preventing transmission. And I'll put a couple of links about how to improve the fit and filtration of your mask and what the CDC is saying.
Great, thank you. We are just about out of time. We will certainly capture the questions we were unable to handle real time during this meeting and try to bring back responses to you all or incorporate your recommendations. Just thank you so much for your engagement, your time, and again, your ongoing work. There's still a lot happening a year into this, and we know a lot of exhaustion is set in. And so just, again, a big thanks for your time today and for all that you do. Have a great day. Thanks, everyone.